Hello my lovely friends, I am Dr. Arun Swami, your physiology faculty. In this video, we'll discuss about the high yield MCQs for upcoming FMG and the NEET PG examination from respiratory physiology. So the first question which can be asked, and the question is, a 32-year-old man develops sudden onset of dyspnea after a long flight. ABG shows decreased PaO2, decreased PaCO2 and increased pH. Which physiological change is most responsible for hypoxemia? Option A is reduced alveolar ventilation, increased physiological dead space, diffusion limitation and reduced hemoglobin affinity for the oxygen. Guys, whenever such type of question asked in the examination, the few catch point you should always have to be remember. The first catch point is the person is in the long flight. The number two, there is the sudden onset of the dyspnea and the ABG interpretation. Now, if you have to be answer such questions, guys, these catch point you should always keep in your minds. And now, please let me know the answer of this question. Guys, we know that if pH is high, it means this is towards the alkalosis. And alkalosis means CO2 is, you can see there is a decrease in the CO2, means the acidic content is less in the body and oxygen content is also less. Guys, please pay attention. If we talk about the reduced alveolar ventilation, in alveolar ventilation, whenever it reduces, when there is any foreign body obstruction into this alveolar area, leading to decreased alveolar ventilation, and it lead to increased CO2 and decreased pH, isn't it? Then the diffusion limitation, this happens when any basement membrane conditions is there, right? And reduced hemoglobin affinity for oxygen, it happens in carbon monoxide poisoning. Carbon monoxide poisoning. Guys, the right answer of this question is increased physiological dead space. How? As the question is describing, the person is having in the long flight and having the onset dyspnea. Now, please pay attention, guys. In long flight condition, when we are sitting for the longer duration, guys, more blood is always present towards the leg side. This leg veins flow is always decreased, and this decrease of flow of the blood leading to stasis, and stasis can have the tendency to form the clots. These clots can be formed into the deep veins, can lead to DVT, and some of any part of this clot can be dislodged from that area and it may stuck into the pulmonary circulation area and may decrease the perfusion into the lungs. Guys, what will be happening? Ventilation is normal, but perfusion is less. The less blood is coming into the lungs, so not all the gas can able to exchange with the blood. So the ventilation is normal, but gas exchange is decreased, leading to increase the dead air or the dead space, right? So guys, that's the reason that there is an increase in the physiological dead space. So guys, the keywords which you have to remember regarding of this pulmonary embolism, that pulmonary embolism, it increase the dead space ventilation via wasted ventilation, means person is taking the air inside, but not all the air able to exchange. So wasted air is more, leading to hypoxemia with respiratory alkalosis. So in prolonged sitting, the slowed blood flow into the leg veins leads to DVT, causes pulmonary embolism, which can decrease the perfusion in pulmonary circulation, leading to VQ mismatch and increased dead space ventilation. And that's the reason, guys, in nowadays, in younger generation, such condition is occurring very fastly, because the lot of people, they are working in their offices, in their that's working areas, and guys, they used to sit for the longer duration. So guys, now onwards, if you are also having the same type of job or the profession, guys, you should always have to stand up after a periodic time period, right? So this condition cannot be occur. I hope now you will never do such mistakes if such type of question can be asked in your examination. So the next question is, the which situation causes the left shift of the oxygen hemoglobin dissociation curve? Option A is increased 2,3 DPG, high altitude acclimatization, metabolic acidosis, and hypothermia. Guys, multiple times we have been studied that in oxygen hemoglobin dissociation curve, we know that there is a mnemonic we called as K date. Whenever the K date increase, the curve will shift towards the right side. The curve will shift towards the right side. And whenever decrease, the curve will shift towards the left side. Now guys, you have to be understand what is the C, what is the A, what is the D, what is the E, what is the T. So we know that C is CO2, A is acidosis, D is 2,3-DPG, E is exercise, and T is temperature. So you can see C CO2, A acidosis, E D, that is 2,3-DPG, E is exercise, and T is temperature. So now you can easily understand that whenever temperature is decreased, this condition we called as hypothermia. Right? Now guys, you can easily answer of this question with this mnemonic, and you can see over here the right answer of this question is hypothermia, because increased 2,3-DPG, this will shift towards the right side. Metabolic acidosis, this is again the right side. Guys, high altitude acclimatization. When the person at high altitude area, guys, there is a decrease in the barometric pressure of the atmospheric pressure. So initially there can be hypoxia, but later when the person is acclimatized, in acclimatization the level of RBC is increased, the level of hemoglobin is also increased, and that condition is never differs in the oxygen hemoglobin dissociation curve. So the right answer of this question is option number D, that is hypothermia. Please remember a few things about this oxygen hemoglobin dissociation curve. This is a sigmoid or S-shaped curve, which you can see into this image. On x-axis there is the partial pressure of the oxygen, and on y-axis there is a saturation of the hemoglobin. It demonstrates how much oxygen hemoglobin carries at the different oxygen pressure, and we know that hemoglobin has the 4 subunits, and each subunit binds with one molecule of the oxygen. So one molecule of the hemoglobin can bind with the 4 molecule of the oxygen. Binding the first oxygen changes hemoglobin shape, and this is lead to from tense to the relaxed state, increasing its affinity for the subsequent oxygen molecule, and leading to this curve is going into the steep rise like this. So the first molecule bind with the hemoglobin with lots of effort, but the remaining 3 molecules they can bind very easily. Hypothermia increase the hemoglobin affinity, causes the left shift. Also remember that left shift will decrease the affinity increase the affinity and decrease the dissociation. Increase the affinity and decrease the dissociation of the oxygen and hemoglobin, but the right shift, whenever they will be there, it will decrease the affinity of the oxygen and dissociation will be increased. Right guys? Also remember that if the one molecule of the hemoglobin can bind with the 4 molecule of the oxygen, then 1 gram of hemoglobin can bound with 1.34 ml of oxygen. Guys, earlier we were discussing about the molecule, but now we are talking about grams, the quantity of the hemoglobin. The 1 gram hemoglobin can bind with the 1.34 ml of oxygen. We know there is average around 15 gram of hemoglobin present in the body. So 15 gram hemoglobin can bind with the 20 ml of oxygen. Always remember, right guys? So this is all about the oxygen hemoglobin dissociation curve. The next question is the which lung volume is increased in emphysema? Tidal volume, vital capacity, FRC, and inspiratory reserve volume. Guys, the right answer of this question is FRC. That is FRC. Right? Now please pay attention. What is the emphysema and what is the different type of volume and capacities? So let's talk about first of all about the emphysema. So you can see in this picture that this is your normal side. This is the normal alveoli, and here you can see this is the hyperinflated alveoli are there, right? Hyperinflated alveoli are there. So emphysema, it's a chronic obstructive lung disease characterized by permanent enlargement of the airspace distal to terminal bronchioles with destruction of the alveolar walls, and there is no fibrosis. So guys, we know the function of alveoli is inflation, deflation, inflation, deflation. If suppose alveoli remain inflated, this is abnormality. This condition we call as emphysema. If alveoli remain deflated, this condition we call as atelectasis. Now guys, please pay attention about the emphysema. What is the primary pathology? The primary pathology of the emphysema is loss of alveolar septa and decrease the surface area for the gas exchange. Now, what is the main cause? The main cause of emphysema is smoking, right? So, today onwards, you should quit the smoking. So, the main cause is smoking. And the second most common cause is alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency. Two types of emphysemas are there. That is, number one is centri acinar, another one is pan acinar. Centri acinar is seen in the smokers and it always happens or mainly happens in the upper lobes, but in pan acinar, this is due to the alpha 1 antitrypsin deficiency, but it present into the mainly in the lower lobes. So this is how you can be differentiate between the centri acinar and the pan acinar whenever you got some type of questions. Guys, you always have to be focused on these types on the clinical part as well, right guys? Now, also remember the physiological changes which happens into the emphysema. There will be the decreasing in the elastic recoil. If recoil is decreased, stretchability increase, means the lung compliances will be increase. Residual volume and the total lung capacity, this is also increased because air can come inside but it can't go outside normally. So the residual volume, the left amount of the volume of air is increased, and also the TLC is increased, and also the FRC is increased. Why? Because FRC is the functional residual capacity is that residual volume plus expiratory reserve volume. This is your FRC. This is your FRC. Then there is also decreasing in the diffusion capacity. The clinical features are there will be the progressive dyspnea, minimal cough could be there, scanty sputum, and also remember there will be a barrel shaped chest. Pinky puffers phenotypes could be there. In blood gases, in early condition, you will see there is a normal PaO2 and normal or low PaCO2. But in later stage, there can be hypoxemia could be seen, hypercapnia can be seen, and respiratory failure will be there. Talking about the different type of volume and capacity. In different type of volume and capacity, guys, please pay attention. Then normally whatever air you are inhaling, this is we call as tidal volume. So the normal inhalation of the air, that we call as tidal volume. When suppose above the normal level of the inspiration, suppose you have done something like this. Right now you are taking your inspiration expiration. So guys, the inspiration part normally we call as a tidal volume. Suppose immediately you start feeling a smell of the samosa. Guys, what will be happening? You done your tidal volume, but when you start getting the good smell, you are doing like this. What is this? This is the extra air which you are able to inhale, and this is we called as IRV, inspiratory reserve volume. Now guys, please pay attention. After that whenever you are doing the expiration, now this is the normal expiration ends, but if you are doing the extra expiration, guys, this extra expiration we called as expiratory reserve volume. Guys, even after the expiratory reserve volume, guys, some amount of the air is always present into the lungs, so these lungs cannot be collapsed. And guys, the amount of air which trapped all the time inside the lung, this is we called as the residual volume. Now if we talk about the capacity, capacity is the combination of the two or more than two type of volumes. So now if I'll ask you that what is the inspiratory capacity, that the total air which you can exhale normally and maximally, that is we called as inspiratory capacity. And guys, this is your complete the normal inhalation part. that the air which you can inspire normally and in the maximum condition we called as inspiratory capacity. Now guys, similarly, the air which actually present after the normal exhalation, your normal exhalation ends over here. Now the air which is remaining after the normal exhalation, that is we called as FRC, means this is the combination of ERV and RV. And guys, if we'll talk about that what is the vital capacity, then vital capacity is the total maximum air which you can inhale, the total maximum air which you can exhale, that is we called as vital capacity. So what happens in the vital capacity? There will be IRV, there will be tidal volume, there will be ERV. That is your vital capacity. And the total maximum air which you can present at a time in the lungs we called as total lung capacity. What we call this? Total lung capacity, which is consisting that IRV, tidal volume, ERV plus residual volume. So this is combinedly collectively all together we called as total lung capacity. Now guys, please pay attention. Any air which we can inhale, any air which we can exhale, guys, if we want to check the volume of this air, we can check it via pulmonary function test, and this is we can check it via the spirometry. But the problem is that with the spirometry, that any air or the capacity which never comes out from the lungs, we can't calculate. So guys, which volume or capacity we can't calculate through the spirometry? The number one is residual volume, number two is FRC, and the number three is total lung capacity. We can't measure through the spirometry because the some amount of the air, it never comes out from the lungs, and if it is not coming from the lungs, guys, we cannot calculate it via the spirometry. So some other methods are there which we can use to measuring the residual volume, FRC and total lung capacity. Coming to the next question, the premature neonate develops respiratory distress syndrome mainly due to. So this is neonatal respiratory distress syndrome, right guys? Why this is happening? A option is increased airway resistance, decreased lung compliance, decreased alveolar ventilation, and the decreased pulmonary blood flow. Yes, guys, this is option number B is right answer. Decreased lung compliance. Guys, we know that whenever the baby is going to be born, guys, this baby is having the starting of the lung functionality. So the lungs should start functioning normally just after the birth. And guys, this lung should be inflate. It inflating means stretchability of the lungs, we call it as a compliance. So compliance means stretchability. Stretchability. Guys, who helps to stretching of these lungs? This is helped by the lipid molecule, and this lipid molecule we called as surfactant. So guys, the substance which helps to increase the stretchability, to increase the compliance, guys, this is we called as a surfactant. Guys, this surfactant is very important substance, very important substance. It is made up from the lipid, especially in the lipid via the phospholipid, very important part. If this surfactant is deficient in neonates, guys, the fetal lungs cannot be mature and fetus cannot able to do the respiration, this leading to respiratory distress syndrome, right? So few things about the surfactant. So the pulmonary surfactant, this is made up from the phospholipid protein complex lining alveoli that reduce the surface tension, and it also increase the compliance. It increase the compliance. So two things you have to remember: the surfactant decrease surface tension, increase the compliance, and deficiency of the surfactant will decrease the compliance and increase the surface tension. Who is producing this surfactant into the lungs? It produced via the type 2 pneumocyte or from the Clara cell. Guys, if both cells is given in the option, then mark with both cells. If type 2 pneumocyte plus Clara cell. But if both are giving separately, option A is type 2 pneumocyte, option B is Clara cell, then better choice will be type 2 pneumocyte. The main component of this surfactant we called as a dipalmityl phosphatidylcholine, also called as lecithin. and the function to prevent the alveolar collapse at the end of expiration and increase the lung compliances, decrease the work of breathing. It stabilizes the alveoli for different sizes and keeps alveoli dry, leading to decreased pulmonary edema. Guys, this having the more effect at the low lung volumes, there will be always a high concentration during the expiration. So this is few things which you have to remember for the surfactant. Now, this surfactant regulation is increased by the cortisol or thyroxine. So the production can be increased by the cortisol thyroxine, which is the steroids, and decreased by the prematurity or the maternal diabetes. And that is the reason, guys, frequently asked MCQ, you have to remember that in diabetic mother, we always give the dexamethasone injection during the labor. This injection is not for the mother, this is actually the baby's lung. Always remember. And the deficiency can lead to NRDS, neonatal respiratory distress syndrome, associated with low LS ratio, less than 2 in amniotic fluid. Few things also please remember. The test which we do for this checking the respiratory distress syndrome, we called as a LS ratio, lecithin sphingomyelin ratio. This ratio should be 2 or more than 2, then this is the normal condition. Question can be asked that surfactant, when it start producing by cells, answer should be 20 to 24th week, 4th week of intrauterine life. If question asks start appearing in amniotic fluid, then answer is 28 to 32nd week of intrauterine life, and it is maximum at 34th week of intrauterine life. Also please remember, it is degraded via GM-CSF. GM-CSF, which stands for granulocyte macrophagic colony stimulating factor. It is degraded via granulocyte macrophagic colony stimulating factor, and guys, it stores in laminar bodies. So these few things you have to remember about the surfactant. The next question, the primary physiological abnormality in cystic fibrosis lung disease is decreased ciliary beat frequency, decreased chloride secretion, increased sodium absorption, or all of the above. Yes, guys, what's the right answer of this question? Yes, so most of you right now is thinking cystic fibrosis, sir, there is a chloride channel defect. The gene which is defect, that is your CFTR gene defect. And most of you are thinking, sir, there is a defect in chloride channel. Right? Now, guys, please pay attention. The right answer of this question is all of the above. There is a decreased ciliary beat, there is a immobile cilia, decreased chloride secretion due to the defect in channel, and also if the chloride is decreased, guys, sodium is increased, right? So sodium absorption is increased. So right answer of this question is all of the above. Now, guys, please pay attention about the cystic fibrosis. The cystic fibrosis, it is a autosomal recessive genetic disorder by mutation of which gene? That is CFTR gene mutation. There is a defect in the chloride ion transport across the epithelial cell, and the primary defect decreased chloride secretion and increased sodium absorption, leading to thick dehydrated secretion. And guys, this thick mucus, because over this lining, this respiratory lining, it is continuously producing the mucus. This mucus should always have to be in the watery form. It should be thin so that it can be easily get off from this area with the help of cilia. But suppose cilia is there, but what is the cilia? Cilia is hair-like projection. But what happens if this mucus becomes so much of thick? it's like become a honey, शहद के जैसा बन जाए. So what will be happening, guys? This mucus cannot get out because the cilia, which them throwing into the retrograde fashion, guys, they become immobile. And in this condition, guys, there will be a trapping of the mucus, which is leading to the leading to that's bacterial infection. There can be a dilatation of this area, which we call as a bronchiectasis. So all of this condition can be occur. This condition we call as cystic fibrosis. What we call this cystic fibrosis. So the key feature you have to remember: CFTR gene defect, chloride ion channel defect, leading to thick mucus, and this is a autosomal recessive disorder. Cilia is immobile due to thick mucus, right, guys? The few things also you have to remember: the organ which involved in this condition, this is your lungs. Then the pancreas, the pancreatic duct is also blockaged because chloride channels is defect. So everywhere is thick secretion is there. Intestine, there will be the meconium ileus in the newborn. What is the meaning of that part? The meconium, that is the first stool after the birth, it cannot come out because this becomes so much of solid part. So this going to be obstruct into the small intestine, most commonly in the terminal ileum, we call as meconium ileus, and it is also leading to male infertility in the reproductive due to the absence of the vas deferens, right, guys? Vas deferens, it is a tube which takes the sperm from epididymis into the urethra. Epididymis, this is the area where sperm is always gets mature. So vas deferens gets the mature sperm into the urethra. What is the diagnostic test for the cystic fibrosis? That we call as sweat chloride test. What we call this? Sweat chloride test. So all of this part you have to remember regarding the cystic fibrosis. Coming to the next question, the apneustic breathing. The apneustic breathing occurs due to lesion in. Yes, guys, apneustic breathing. So what is the apneustic breathing? In apneustic breathing, there is an increase inspiration, decrease exhalation. Increase inspiration, decrease exhalation. So your person is doing something like this. Inspiration is prolonged, but expiration is decrease like this. Inspiration prolonged, expiration decrease like this. So why this is happening? Because the inhibitory response is delaying. And who is giving the inhibitory response? Guys, all these centers, respiratory center, which we discussed during the classes as well, these are your medullary and pontine centers, and in this both areas, the pneumotoxic center was there, which actually blocks what? It blocks or inhibit the apneustic and the DRG to decrease the inspiration, right, guys? So it is actually doing like a break like condition. So this is your right answer of this question is pneumotoxic center, right, guys? Pneumotoxic center. So what are the different respiratory center? Please pay attention over here. So this is your brain. In the brain, we know that this is the area we call as brain stem. In brain stem, there is two areas is there. This area we called as pons, and this area we called as medulla. What we call this? Medulla. Now please pay attention. The three centers present into this area, into the medulla, and the two center is present into the pons. So total 5 respiratory centers are there in the brain. Now guys, please pay attention. Why there is a 5 respiratory center? Because the first center, this which is present into the medulla, we called as a DRG, dorsal respiratory group. This is present anteriorly, we called as ventral respiratory group. And guys, below at this area, the another respiratory group is present over here, and this respiratory group we called as pre-Bottinger complex, which is the pacemaker of the ventilation or the respiration. So pre-Bottinger complex. So whenever we are going into the sleep condition or in the unconscious state, guys, who will take the command for the respiration? This is taken by the pre-Bottinger complex. So we never thinks about the respiration during the sleep that we have to do the respiration. अपन कभी भी ऐसा नहीं सोचते हैं. Why? Because thanks to God, that God has given us pre-Bottinger complex, right, guys? Now, so you can easily see the 3 centers are present into the medulla and 2 center into the pons, that is your pneumotoxic center and the apneustic center. Guys, please pay attention. The normal respiration, The normal respiration which you are doing, this is done via the DRG. This is done via the DRG. So this is the normal inspiration. So right now you have done your normal inspiration. This is due to the DRG. Now if you want to do the forceful exhalation, this forceful exhalation if you are doing, this is you have been done via the VRG. So this is for the forceful exhalation. Guys, the normal exhalation is passive, but inspiration is active, forceful exhalation is active, and this is done via the DRG and the VRG. Then the apneustic center, suppose you want to take some extra air inside. The normal inspiration is done by the DRG. Lekin suppose if you are smelling the samosa, guys, you want to take little bit more air inside. Guys, who will give this command? Who will allow you to take more air inside? Guys, this is done via the apneustic center. So it increase the inspiration depth. It increase the inspiration depth. And guys, who is controlling this inspiration? Because all this center they are doing the inspiration, there could be a chances lung can be burst out. So guys, who is going to be prevent this inspiration? Guys, this is done via the brake we called as pneumotaxic center, which limit the inspiration. And you can see that they are attached, these centers are attached via the motor nerves, So this is how your different respiratory centers are present and their functions are there. So now what happening, as the question is saying that apneustic breathing occurs due to the lesion end. So guys, apneustic breathing, as I already told you, the inspiration is prolonged, expiration is shortened. Why there is? Because the brake is filled. So apneustic and the DRG, they are overactivating and leading to increase the inspiration. But there is something we call as a J receptor, which gives the Herring-Brewer reflex. And guys, this Herring-Brewer reflex limit the inspiration. So this is how the apneustic breathing can be seen. So in the respiratory center, just now we discussed, the location are in brainstem, medulla containing the primary rhythm generator, pons modulates the rhythm and the pattern. The medullary centers, this is the DRG, which is located in nucleus tractus solitarius, required for quiet inspiration, receive input from the chemoreceptor and the vagal afferents. Then the VRG, it is active during the forced breathing, control inspiration and expiration, contains pre-Bollinger complex, which is the basic respiratory rhythm. Also remember, in the pontine centers, the pneumotaxic center, which limit the inspiration, it increase the respiratory rate, leading to short inspiration. And apneustic center, it prolong the inspiration, causes apneosis if unopposed. Guys, the chemical control is done for this respiration is done via the chemoreceptor, which is two type. One which is into the brain, we call as central chemoreceptor. Another one is present into the aorta and into the carotid artery, we call as peripheral chemoreceptor. Guys, always please pay attention. The central chemoreceptor is sensitive for increased CO2 followed by the H ion. But the peripheral chemoreceptor, it is respond mainly due to decrease the oxygen level. So guys, please pay attention. If this is the brain and this is your aorta and this is the carotid artery. One center here, one center here, these centers we called as chemoreceptor, which is responsible or sensitive for oxygen. But the center which inside the brain we called as central chemoreceptor, and guys, this is sensitive for the CO2 followed by the H ion. And remember, the vagotomy means the cut of the vagus will lead to slow and deep breathing, and pontine lesion leading to irregular respiration. So I hope that most of the topics which just now we covered into this session now is clear in your mind, guys. So I hope you will never do those mistakes which earlier you have been done. So this is all from my side. Thank you for watching this video.